Welcome to the ONC Health IT Certification Program Developer Roundtable. My name is Tom Deneen with Kaufman and Associates, and will be assisting with the logistical support for the Zoom session. The materials contained in this presentation are based on the provisions contained in 45 CFR Parts 170 and 171. While every effort has been made to ensure the accuracy of this restatement of those provisions, this presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations. Please note that other federal, state, and local laws may also apply. This communication is produced and disseminated at U.S. taxpayer expense. You can ask questions by clicking the Q&A button, which is located towards the bottom part of your screen. Click on the Q&A bubble icon, and this will pop up the Q&A box, which will open to the right side of your Zoom interface. You may also use the raise hand function under reactions, and we will unmute your line to verbally ask questions during the session. Additionally, we ask that you select the speaker view option located at the top right side of your Zoom interface. This will allow you to see the speaker as they present or share information. If you need technical assistance during the session, click on the chat bubble icon at the bottom of your screen, and this will pop up the chat box, which will open to the right side of your Zoom interface. Please type the issue into the chat box and one of our techs will respond to you. Finally, please be aware that today's session is being recorded. Closed captioning is available and by clicking the CC icon at the bottom of your screen. I will now turn it over to Robert Anthony.
Thank you. Welcome everybody, and thank you for joining us again for another developer roundtable here for ONC's Health IT Certification Program. Today, I will be speaking a little bit. We will also have Sean Spurlock, who is on our team in the Certification and Testing Division, and Andrew Hayden from ONC's Standards Division in the Office of Technology. He is our lead coordinator within ONC for the standards version advancement process. Next slide. I, of course, am the director of the Certification and Testing Division. We administer ONC's Health IT Certification Program. Today, we are going to do a little bit of a refresh and a little bit of new. So for those of you who are not paying attention daily to everything that ONC does and releases, first of all, shame on you. Secondly, we have released today the approved standard versions that have been advanced for 2023. We're going to cover that in the latter portion of today's meeting. We are first going to go through and do a refresh on B10 Electronic Health Information Export, and I will be doing that for you today. Please do populate any questions into the Q&A. I am going to try personally to look at those as I go along and try to answer as we are talking. But if we are not able to get something during that, we will try to address it afterwards. There will be some time for some Q&A at the very end. If there are other things that are not related to either B10 EHI export or the SVAP process, we would be happy to address those as well. And then, of course, the burning question that everybody always has, yes, these slides will be available later, as will the recording of this presentation for your later viewing. Next slide. So for B10 Electronic Health Information Export, we covered some of what I'm about to talk about at the last quarter developer roundtable. So I apologize to some of you if you have already sat through some of this information. But I think that everybody knows the upcoming B10 Electronic Health Information Export requirement is fast approaching. Technically, regulation says that it must be in place and available by December 31st of this year, so the very end of this year. However, I would caution many of you to please check with your ACBs. They have some earlier deadlines. Many of them are in October. I think one of them even has one toward the end of September, which means that you want to get the process started now because you are not very far away from that. Most of what I'm going to cover here is some things that we talked about last time, but there are a couple of new questions that have come in, and I just want to make sure to share those answers for everybody so that everybody understands where we are at. Next slide. Of course, the B10 electronic health information export is a criterion that replaces the previous 2015 edition data export criterion B6. That will be sunset at the end of this year. You are required to make this, to be certified and make this available to end users by December 31st of 2023. It is a developer requirement, not necessarily a specific product requirement. And it allows providers to export all of the electronic health information that is stored in a certified health IT product for two use cases, either a single patient or an entire patient population. And it does also allow individual patient access to electronic health information. Next slide. Who is required to be certified to B10? This is a question that comes up a lot. Again, this is a maintenance of certification requirement. That is where you will find the B10 requirement and the requirement deadline within the assurances maintenance of certification requirement. This is binding on all developers that participate in the program. It does not matter what type of product you have. What matters is, do you store electronic health information as it is defined according to the regulation? And we have a slide here that sort of talks about that, but the preview, of course, is that electronic health information is information that is in that HIPAA designated record set. So if you are a developer who has a module that is part of a larger product that stores electronic health information, if you use relied upon software, if you leverage a third-party EHI storage, you may be required to make sure that you are making this available to folks. A question that has come up recently is whether the product itself needs to be certified to B10 or whether a B10 certification needs to be made available. And I know that may sound like the same thing, but for many developers who have multiple products, it isn't. The important thing is that that B10 certification needs to be made available to folks. So the product itself does not need to be individually certified to B10. However, a B10 certification does need to be made available to the end consumer so that that EHI can be exported. So in other words, you could have B10 in another product that you make available that would give people the ability to export that electronic health information. If you feel that your product does not store electronic health information, if you feel that your module doesn't store it, doesn't cause it to be stored, is not part of a larger product that stores electronic health information, then you want to talk as soon as you can with your ACB to provide documentation about why you feel like B10 does not specifically apply to you. We want to make sure that nobody is in the situation that as the deadline approaches, they discover suddenly and inadvertently that B10 does apply to them. And then finally, can you just direct customers to a third-party solution and not have to certify to B10 themselves? That answer, of course, is somewhat, it depends. At the end of the day, you need to provide B10 certification capabilities. You can do that as relied upon software. You can do that as a certification criteria that is available in another module that you have, but customers do have to have access to B10 certification that allows them to export electronic health information from your larger product that stores that EHI. Next slide. So what is electronic health information? So EHI is EPHI. Some of you may know this, but that is electronic protected health information to the extent that it's included in a designated record set as defined at, you will see this clickable link here to the Federal Register notice, but that's essentially the HIPAA designation of what is electronic protected health information. Just as with the HIPAA designated record set, we indicate that EHI does not include psychotherapy notes, nor information that is compiled for a lawsuit, essentially civil, criminal, administrative actions or proceedings. We often get questions about does this piece of data need to be included in EHI export? And I would say that you want to ask yourself these two basic questions. Is it stored by the product of which your module is a part? So in other words, your module itself doesn't need to store the data. The data doesn't even have to be generated by the module that you have certified. But if you deploy that certified module as part of a larger software package, a larger software product, and that product causes EHI to be stored, then you're going to have to include it in the EHI export. And then, of course, ultimately the question is, would it qualify under that definition of designated record set above? The answer to either of those questions is yes, or if the answer to both of those questions rather is yes, then you do need to include whatever that data is in your EHI export. Can information that is outside of that definition be included in the EHI export? And you will see that we have another question that came in again about this. Nothing in the program places requirements on what EHI can be exported under this functionality beyond what is defined in regulation. So that is a long way of saying if it is in the designated record set, then it must be. Anything beyond that is purely at the developer's discretion. The minimum floor here is things that are defined in that designated record set. Next slide. The file format requirements are something that we get a lot of questions about. B10 as a functionality or as a certification criteria was defined around the idea of functionality. But a lot of flexibility is given to developers in how they actually deploy this because all systems are a little bit different. The requirement here is basic transparency. All of those EHI export files need to include a up-to-date hyperlink that allows any user to directly access format documentation information. So basically what we might call a data dictionary, so that you can use that export format documentation to process the electronic health information after it's been exported. So essentially you could use that data dictionary to be able to see how to crosswalk this to import information into another system. It should describe, the format should describe the structure and syntax of how the information is exported, but of course it is not specific to the information itself. The file of information that is exported must itself be electronic and in a computable format. That often leads to the next question that we get from folks. Can the export be a PDF? And I will tread slightly carefully here and say it depends on the nature of the PDF. A PDF is electronic, but not all PDFs are created equally. So in other words, not all PDFs are computable. If you have a PDF that is computable, that is, it is machine readable, that is, it is able to, another system can look at individual fields to extract data from that PDF, and it would be considered electronic and in a computable format, and you could use a PDF formatted in that way. However, there are a number of PDFs that are what I would just call flat PDFs. They don't have a breakdown of individual file fields. You could not export that information from the PDF, and that type of a PDF would not be allowed. But otherwise, essentially, it is, can the export be a PDF? There's a question here about how you can tell if your PDF is computable. Is there a way to test this? There are a variety of ways that you can look at this. There are a variety of tools that are available on the internet. However, I think a very easy way of looking at that is if the PDF is essentially a scan or a what I would characterize as a digital printout that you cannot individually select information from, that PDF is not going to be computable. If that PDF allows you to select data but doesn't allow you to make a distinction between fields, then that is not going to be a computable format. It is it is copy and pasteable, but it is not necessarily computable. I would ask people to do a little bit of digging on internet resources that'll give you a little bit more about what the difference between a computable PDF is and others. Next slide. So one of the cases that you have to support, there are two cases you have to support under B10 functionality. We specifically call these out in the Cures regulation. One of them is being able to support single patient export. So exporting all of the electronic health information that is under that definition that applies to a single patient. This needs to be done very specifically without developer assistance. We call that out in regulation. So in other words, and I'm not saying that it has to be done specifically in this manner, but we sometimes refer to this as push of a button. We really just mean that if a user chooses to export that information, they can do it without having the developer intervene in any way. That does not, however, mean that there needs to be direct-to-patient functionality. What is required by regulation is that this can be done on the provider or the user side. So in other words, an end user, whether that is an administrative person within an organization or a physician or whomever, should be able to access the EHR and export a single patient EHI. It does not mean that a patient has to have that functionality at their own fingertips. Of course, you have to create that export in a timely fashion. It has to include all of the EHI, just like everything. It has to be in an electronic and computable format, and it has to include that publicly accessible hyperlink to the data dictionary, the export format. We also include, you do need to be able to limit the number of users who can perform an EHI export. That's a system security thing where you need to be able to indicate that only specific people are able to do this if an organization so chooses. Next slide. I do see a question here where somebody asked about reviewing a scenario in which a module does not need to certify, but rather can make the B10 export capability available. This is true as of any other certification functionality. You can provide that either within the module itself, or you can provide it as relied upon software that is referenced to another certified module. Either way, that B10 export functionality needs to be made available to the end user. And in both of those situations, you would technically certify, but it's a question of whether you certify your own B10 or whether you use relied upon software for that B10. But either way, if you have, if your health IT module is part of a product that causes electronic health information to be stored, there must be some sort of B10 certification available. Patient population EHI export. So the other case that a B10 functionality must support is an entire patient population. So basically all of the electronic health information that is in a patient population. We call out specifically the use case of being able to move all of your information from one EHR system to another system. That is part of what this is intended to support. Again, this must be electronic and in a computable format. You got to have that hyperlink access to the format, the data dictionary. But we do specifically say that this could require the action or support on the part of a health IT developer. In other words, it doesn't need to be solely executed on the user side. It doesn't need to be completely push button and solely executed on that side. There definitely could be a workflow in which a developer intervenes. I think most people who are looking at things on the large patient population export level do have some level of developer manual intervention in the process itself. Next slide. We often get this question, and we've gotten these questions again, so you'll see this pop up at the very end, but we get questions about HISPs and HIEs that have functionality that is certified, and do they have to certify to B10. And I think that it basically comes down to, do you store EHI that would be under the designated record set for HIPAA? That means that it is, according to HIPAA, available. So it comes down to the scope of the electronic health information that is stored by the product at the time of certification. So we often see we can't see inside of messages. If a message is encrypted and the encryption is stored and there is no access to electronic health information within the encrypted message, then you are not in fact storing electronic protected health information according to the HIPAA accessible definition. So you do not need to worry about certifying to that. However, many HISPs and HIEs do act as intermediaries for data that is visible to them or is stored at that HISP and HIE. And in that instance, they would need to employ that B10 functionality. Again, so if you are doing this, then if you have that information available, then it needs to be provided with that B10 certification functionality. Next slide. I'm going to stop at a couple of questions that we've gotten in the meantime. For charges with B10, can a company associate costs for custom exports that are different from the B10 export offering? Or perhaps if they want to export all data for moving vendors and want the export in 1 day instead of 2 days. That gets into an area that we do not regulate. What we regulate is information that must be provided under B10 and a requirement under B10 that the export must be quote unquote timely. We don't put a specific day period on it. So if you are doing something beyond what the B10 export requires, both from an information capacity and from a timeliness, we do not regulate the costs that are related to that in any way, shape, or form. Let's see, there's another one. Could G10 bulk fire export be used to comply with that if it allows them to select or export a single patient? So theoretically, yes. We've had this question before. It's going to depend mostly on the scope of data that is stored by your system. If the scope of data within your system, the EHI within your system, exactly matches up to what is exportable by FHIR, then you could leverage that. There's nothing, we don't prescribe how that needs to be done. I will say, however, that the definition of electronic health information is much broader than what is within, say, the US CDI, the US Core data set for interoperability. If you have additional data, then the G10 bulk fire export or G10 API functionality would not be able to be solely used in order to meet that. And as far as the data dictionary being the website documentation, no, there is a requirement that the developer has to maintain a accessible hyperlink to a data dictionary that indicates the format of what is returned to people. That certainly could fold in information about HL7 and FHIR, but you're going to have to put together some custom documentation. Do you need to hyperlink on each file of EHI export, or can it be provided on a user interface screen only? I'm not exactly sure of the intention here, but so I will tell you exactly what the law says or the regulation says. And the regulation says that you need to provide with each export must contain a accessible hyperlink that maintains the export format documentation. So that is the minimum required. How you meet that is really up to you. There are not standards for timeliness about provision of information. There is not a difference between single patient and population. It is a flexible time period, but we do talk a little bit about this in the preamble. It would be a reasonable expectation for being able to do this. And then somebody asked, can you export in the QRDA1 format? I am familiar with the QRDA1 format, and unless the only information that you store in a system or in the system of which your module is part is specifically clinical quality measured data related to QRDA, I find it difficult to believe that you would be able to use QRDA1 solely for your EHI export, but it is possible in very limited circumstances that that could be the case. I'm going to move on to the slides here, B10 and information blocking. There's a question that often comes up. Do you need to have this in place to comply with information blocking requirements? B10 is not explicitly designed for this. It is not specifically about information blocking requirements. B10 is a developer requirement. It is not a provider requirement about information blocking and making these things available. It is a maintenance of certification requirement that is incumbent upon developers that participate in the health IT certification program to make EHI export functionality possible. And we specifically identify that the functionality is available to end users so that they can support those cases of exporting single patient and whole patient population data, but it's not specifically designed to fulfill information blocking requirements. Next slide. Just want to point people to a couple of things here. We have a fact sheet for more information that I would steer people towards. Pretty 101 basic overview of everything you can find here. We also have a certification companion guide that is sort of our place for guidance. And if we issue any type of clarifications, they always end up in the companion guide. You would find both of those on our website. And when you get these slides, they will be clickable links that you will be able to look at. Next slide. And now we are going to turn to the, oh, actually, wait, I'm sorry. I was going to check. We do have a couple of more questions here. Does access to the portal and the data in the patient portal meet the requirements as long as the data in the portal can be exported? Again, that's really going to depend on what type of data is supported, but keep in mind that a patient portal is designed for the patient to have access to their information, whereas the B10 certification, the B10 functionality is designed for single patient EHI export for the end users of the actual technology. So generally providers and staff. There is not a specific requirement for patient provision, but certainly there can be ways that developers could leverage already existing technologies to make that available. However, I would note that most patient portals currently do not make all of the EHI, everything that would be under the designated record set, accessible to the patient, and that would have to be something that would have to be done. There's a question about single patient EHI export. Is it a requirement for it to be human readable format for a patient? So no, that is not a requirement for this. Again, the requirement is to be able to export all of that information and to provide an accessible link to documentation that describes the export itself, so that that data can be computable and used in another area if it needs to be. It is certainly possible, and I think many folks do aim, to the point above, to sort of make both things available so that it is also human readable. But that is not the requirement, nor is it the specific intention of B10. B10 is not meant specifically for patient readability. It is specifically meant to support the export of all electronic health information. Do you need to provide EHI export for deceased or inactive patients as well? This is, again, not a provider requirement. This is a developer requirement, and the developer requirement needs to support any single patient export and a full population patient export. A health IT developer who has ancillary products like a patient portal that is not standalone, the portal provides CCDA to the patient. Does the portal or other products like it require direct B10 certification if the information provided by the portal is redundant to information pulled from the EHR? So that might be a circumstance in which the information, the EHI within the product, directly lines up with everything that would be exportable to the patient. So you could be in a situation there where in a portal, you would have a one-click button that is available to users, also available to patients, that provides all of the information that is within that module. And since it's part of a standalone product, there isn't additional electronic health information. However, keep in mind that the other requirement for B10 certification is that for a single patient, an organization does need to be able to limit the users that have access to that information. So there would presumably have to be something on the back end on the portal that would limit that amount of download. So I would encourage you to have a conversation with your ACBs about how exactly to approach that. Can you use the US CDI data in a CCDA document and the rest of the EHI in a PDF? We don't prescribe, and we don't say that every single thing has to be in a single export file document. In fact, depending on the system, especially if you have images that are associated within a system, that can be very difficult to provide in that way. So it is certainly conceivable that your file format export could have multiple different approaches to it. However, you would have to account for that within whatever data dictionary, the file export format documentation that you make available, so that somebody could decode that and figure out how to consume that information elsewhere. And as far as upcoming updates to regulations, we cannot comment on anything that might be upcoming within regulation. We can only comment on what is currently required by current regulations. With that, I think we have reached the end of those questions and answers. I will turn to the standards version advancement process and turn this over to Sean Spurlock.
Thank you, Rob. Before Andrew from our standards division goes over the approved SVAP standards for 2023, which were actually released this morning, I wanted to take a moment to provide a brief overview of the SVAP cycle, how it works, and how health IT developers can incorporate SVAP standards into their health IT products. Next slide, please. What is SVAP and why is it important? So ONC implemented SVAP as part of the real-world testing condition and maintenance and certification requirement as a means for developers to voluntarily incorporate newer, more advanced standards into their health IT products and modules than those that are adopted in regulation. This was done for a variety of reasons, one being that it relieves time constraints for incorporating more advanced standards into our certification program, as SVAP does not require a formal rulemaking process, which those of you who know that rulemaking is a very long and time-consuming process. SVAP, as an annual process, institutes a predictable and timely approach within the certification program to allow us to keep pace with the industry's standards development efforts. And SVAP also supports ONC's commitment to interoperability in the real world, as new standards are approved based on the insights gained from real-world implementation and use of these standards. Next slide, please. So SVAP in regards to health IT certification. And so as I noted, SVAP is limited to standards adopted in the certification criteria needed to satisfy the real-world testing condition of certification. I will go over the real-world testing criteria in the next slide. For now, so SVAP provides developers with flexibility not only at the time of a module's initial certification, but also during the maintenance of a module certification. SVAP also ensures version updates are effectively implemented and allows ONC to effectively implement updated standards that coincide with real-world testing plans and results. Just a reminder, these slides will be shared following the presentation, and this link shown at the bottom, provides a high-level overview of the SVAP process as it relates to the certification program. Next slide, please. So shown here are the applicable real-world testing criteria. I'm not going to go through each one of them, but I did want to point out how they're categorized, which is as follows. They're care coordination, clinical quality measures, patient engagement, electronic exchange, public health, and APIs, or application programming interfaces. For more information about these criteria, each of these is linked to their associated certification companion guide, which provides greater detail into each of these criteria and how to meet the requirements for each of the criteria. Next slide, please. So using SVAP. I want to point out that leveraging SVAP standards is strictly voluntary. There's nothing that requires a developer to use the SVAP standards or incorporate them into their health IT modules. Certified health IT developers choosing to leverage the SVAP flexibility can do so on initial certification of the health IT module or to maintain certification of the module. That's a few requirements for developers incorporating SVAP standards into modules that have existing certifications. Developers must provide advance notice to all affected customer as well as their ONC ACB that adequately expresses their intent to incorporate the updated standards into their modules, expectations for how these standards will affect the interoperability and other functionality of their modules, and whether or not they would continue to support certificates for the existing version of the health IT module. For both existing and new certifications, developers will need to successfully demonstrate conformance to the SVAP standards under certification program requirements, and also maintain updated certified health IT modules within full conformance of all certification program requirements. And just to note that this also includes updates to real-world testing plans and results. Next slide, please. Okay, so just a high level of how the SVAP cycle works. This animation to the right of the slide just gives an overview of the cycle. So SVAP is an annual cycle where the certification division and the standards division collaborate to identify, approve, and make available newer, more advanced versions of standards. Once ONC proposes standards to be included in a given SVAP cycle, there is a 90-day public comment period, which is then followed by an internal comment review period. Once final determinations are made of which standards will be included in a given SVAP cycle, the approved SVAP standards are released and then made available for use after a 60-day delay period. So as I mentioned, the 2023 SVAP cycle standards were released this morning and will be made available for use in the certification program beginning September 11th of 2023. All right, next slide, please. And just to point out some dates for the current SVAP cycle, the public comment period opened February 21st of this year, followed 90 days later on May 22nd, 2023 is when it closed. The standards were announced this morning. Like I said, will be available for use September 11th of this year. And the 2024 SVAP public comment period for the next cycle will begin in February and then again close 90 days later in May of 2024. Next slide, please. Okay, so previously approved SVAP standards. A version of an adopted standard approved for use during any SVAP cycle remains available for certification until a newer SVAP version of that standard is approved. Once a newer SVAP version of the standard is approved, the previous SVAP version will no longer be available for use in the certification program. Certified health IT developers do not need to keep advancing to newer SVAP versions once they choose to leverage SVAP. No new certifications can be made to the replaced SVAP version once the newer version goes into effect. And any certification to replace SVAP versions will continue to be valid. The below link contains a list of all previously approved SVAP standards, including the 2023 standards that again were released today. Next slide, please. Included in this slide, it's just a list of the certification programs, SVAP resources that contain insights into how the process works, how to leverage the approved SVAP standards, and the approved standards themselves. I will now turn it over to my colleague, Andrew Hayden, from the Standards Division to discuss the 2023 approved SVAP standards.
Great, thank you, Sean. My name is Andrew Hayden. I'm the SVAP Coordination Lead for the Office of Technology Standards Division, and I'll be going over the approved standards for 2023. Next slide, please. Here you can see we have an overview of the 2023 approved standards. We had 6 standards that were reflective of public comment. Sean just went over the comment period date. And you can see on the screen the commenters all were in favor of moving to US CDI version 3 from V2, provided it was in tandem with the latest versions of US Core and the CCDA companion guides. And all were in favor of advancing the latest annual updates to QRDA 1 and 3 related to the CMS quality reporting program. And we have as well US CDI V3, and we'll see a list of the standards coming up, but US CDI 3 and US Core STU 6.1.0 and and the CCDA companion guide, release 4.1, and all 3 of those standards will move the industry towards consistent implementation of US CDI v3. And to support implementation of the 2023 approved standards, ONC is updating all of the associated test data and tools. So if we could go to the next slide, please. Here are the actual standards. As you can see, we have the 3 related to US CDI v3 and moving industry towards consistent implementation of US CDI version 3. We've got the latest US Core, IG, the CCDA companion guide, release 2.1, release 4.1, that was released in June. We've got the 3 annual updates to QRDA as well that I just discussed. And we are advancing the most recent versions of those annual updates that relate to the CMS quality reporting program. Next slide, please. So here we have the latest version of US Core, STO 6.1.0, which was recently released. This, as I said earlier, kind of aligns with US CDI v3. It's proposed as the new baseline for certification and ONC rulemaking, and it will continue to advance health equity, reduce disparities, and support public health data interoperability. Pardon me, this is US CDI. And this was reflective of public comment support of all public commenters that were in favor of US CDI v3. There were several new social determinants of health and clinical care data elements and new guidance on how to improve interoperability between different healthcare systems that you'll see in US CDI v3. Next slide, please. This is indeed the US Core IG. This also reflected public comment support. All commenters were in favor of advancing the latest version, which is STU 6.1.0. US Core 6.1.0 includes new and updated resources to meet US CDI v3's new data elements and classes. And the Inferno test tool will accompany all recent versions of US Core and will be also updated to include STU 6.1.0. Next slide, please. This is the updated CCDA companion guide. This too was advanced due to great public comment support. It also supports US CDI v3 and it's proposed in ONC rulemaking. There are new CDA templates added to accommodate US CDI v3 data elements and also backwards compatibility conformance guidance on using new or revised templates supporting US CDI v2 and v3. Next slide, please. Here we have the HL7 QRDO1 annual update. This is a standard that relates to patient level quality reporting. There was great public comment support for advancing this standard, and it's notable because it's the first advancement of the C1 and C2 certification criteria. Again, this is an annual auto advance standard. Next slide, please. Also related to the CMS quality reporting program, we have the latest updates to CMS QRDA 1 2023 and CMS QRDA 3 2022. As mentioned, these pertain to the quality reporting requirements, and this is just an annual update. We updated them annually last year as well during the SVAP cycle. Now I will be turning this over to Rob and or Sean to address questions from the Q&A portal. Thank you.
So I am going to ask, can we back up to slide 27? And one of the things that I did want to draw attention to, this is not usual for us. I think that Sean covered our general process with US CDI is that, I'm sorry, with SVAP, is that once a standard has been advanced under the standards version advancement process and becomes effective, the previous SVAP version of this is no longer available for developers to upgrade to voluntarily. So in other words, there are always two standards that are generally available to developers to advance to. There is the, or I'm sorry, to be conformant to. There is the regulatorily required standard, and then there is whatever the latest SVAP approved standard is. So new years replace previous years. Except in this particular instance this year. We are actually extending the US CDI version 2 availability timeline. Normally, the availability for certification for US CDI version 2 would end as of the effective date for the SVAP, which is September 11th. We're actually going to extend that until the version 3 US CDI and US Core associated guide are available as a test kit on our website in Inferno. So we anticipate that that will be the end of the year. That'll be around December. So essentially between now and the end of the year, developers will be able to either be conformant with US CDI version 1, US CDI version 2, or US CDI version 3. You will not be able to advance directly to US CDI version 3 until the tool is available. So if you are not certified at all to any of the certification criteria on the right that utilize US CDI, you would either have to go to version 1 or you would have to wait until the tool is available. You can, however, directly certify to version 1 or version 2. Of course, if you're already certified to any of the criteria on the right-hand side, you can advance through the SVAP process to whatever version at any time, obviously, once version 3 is available. So basically expanding a little bit of that timeline for version 2, not a typical approach for us, but we wanted to make sure that that was available to everybody. Then there is a question about, there's been a couple of questions here about QRDA, answered one of them in the chat. Obviously, you could see that we do advance QRDA through the SVAP process, but that process does not align with the CMS reporting timelines. However, traditionally, developers have had to advance that, and they simply advance outside of the program. That will continue in this way, we think, and they will notify after that has been available for SVAP. There's another comment, when are we just going to pull that from SVAP updates altogether? This is one of those areas in which there are certain things that are required by statute. There are certain things that we do to align them, and there are certain things that we do so that developers can make sure that they are indicating their most recent advance as soon as they can on the Certified Health IT Product List, which is our system of record. So even though our SVAP for QRDA lags behind the programming releases of QRDAs and the adoptions by developers, it will continue to be this way so that we can allow developers to indicate their conformance to the latest version on Chapel. And then there's a question about how SVAP works for certifications with inherited certified status. It essentially works the same way as anything. An inherited certification status allows you to get certified to the next version. I think we clarify some of this in our SVAP documents, but sorry, I'm reading and responding at the same time. If you're inheriting all of the previous certified criteria, would you be allowed to inherit using US CDI version 2, or would you have to, oh, I see, I'm sorry. So you're asking if you want to upgrade your product using inherited certification status to a new product version, you were on version 2, but version 2 is no longer available, right? So we'd be talking about January of next year potentially, and only version 1 and version 3. Inherited certification status will still allow you to continue on with whatever version you were last certified to. So there's nothing, and this is an important part of the standard version advancement process. It is a voluntary process. There's nothing that requires you to go to the next iteration of this. So you would not be in a situation under ICS where you would be inadvertently forced to go to the next one. I have no comment on the HTI proposed 1 rule because we are still in the middle of rulemaking, but you can see that we have version 2 and version 3, and version 2 will sunset once we have the Inferno tool updated. We'll keep the line open maybe for a couple of minutes to see if we have any other Q&As come from folks. But in the meantime, I would urge people, as always, to take a look at healthit.gov. Our website specifically is in the slides that we will distribute. That's where many of our certification resources are. And if you have specific questions about any requirements in the program, you can always submit information through our website there. There is a customer service response that I colloquially, it's based on JIRA, so we talk about JIRA. I'll ask maybe Kyle, if you are on, if you want to talk about capturing data elements that are not native in US CDI. I think this is more of a question about US CDI.
Sure. Hi, Rob. Here I am. And this is I'm just looking at the data elements outside of US CDI versions. Let's see. So I think, so when there are, and I'm going to just read the question, when there are data elements that are mandated in the US CDI versions that do not naturally reside in the EHR, what is the requirement to develop and capture the data element? The requirement still holds, and we get this question actually quite a bit from developers that are looking at specific systems in different care settings. But I think that the real takeaway and the way to look at this is that any certified health IT product needs to be able to interoperate data across different types of settings. So the requirement is there, with US CDI corresponding criteria. and within the implementation of the either the US Core implementation guide or the CCPA guide.
Thank you, Kyle. A couple of questions other that have come up during the SVAP process. Do you use the original test certification requirement? In other words, if you go to advance to the next version of a criteria, do you have to go through the proctored exam or the test tool or whatever it happens to be? And no, that is not the process for advancing to the next one. SVAP is, the process of SVAP is outlined in some of the resources on our website, but essentially it will involve a process of notifying your developer or your ACB that you are advancing to the next version of this so that they can indicate it, a process of notifying your end users so that they can take advantage of it and they know that that is there for them. And it will happen in that way. And then you will account for it in your real world testing plans and results. If information blocking is being exercised on a client encounter, would that encounter then still maintain that blocking when single patient or bulk patient population is generated? Or does the export include all data regardless of exercising information blocking provisions? I think a simpler way of saying this is information blocking requirements and B10 certification requirements have nothing to do with each other. The information contained in each of those may have a Venn diagram overlap, but there are requirements for all covered entities relative to what they cannot do in information blocking. And there are requirements for developers who participate in the program about the functionality of what must be provided under B10 EHI export. And while it is conceivable that the functionality of B10 could be leveraged by some end users to provide information under information requests and therefore not be information blockers, that is not the intent of B10, and it is not what B10's functionality is designed to facilitate. So I think you want to think of those as very separate things and think instead about how do I meet the individual requirements of those two different things. I'm going to take a brief chat. In the webinar chat, will ONC B10 test be available on Inferno testing tool? No, that is not the case. B10 does not have an associated test procedure or an associated test tool because every developer may have a different way of trying to provide that functionality. And in fact, many developers have different ways of providing the functionality for the two different use cases of single patient versus all patient population. There's no way for us to develop a specific test tool for that. The attestation and documentation is the way of meeting this, and you should check with your ACB about what they are going to require in that area. All right, I think we have come to end of questions. Thank you, everybody, for many good questions. Thank you all for showing up today. Hopefully this has been helpful. Visit our website, and everybody have a great day.